Hey YouTube, it's Marita from the Nurse Lounge. I just want to come in here and say, first, thank you all to my new subscribers. I have several new subscribers to this channel, and I wanted to say thank you. And in addition to that, I want to tell you a little bit about myself since we have so many new subscribers. And then after that, we'll get into what this video is really about. So, my name is Marita, and I'm a registered nurse. I've been a nurse for 15 years. I have my degree, my master's degree in nursing education. So I am a nurse educator. I do come here giving you evidence-based research. If it's not evidence-based, it's based on my personal experience. That does not mean that it is that way everywhere you go. But I am giving you my perspective, my experience based off of what is factual, not just some hoopla about nursing and what it is. So if you're coming here for either for my nursing experience or just it's evidence-based. So in addition to that, I am a doctoral student. I am going to finish my degree in May of 2020. So I will have my degree in executive leadership. And so I consider myself to be a reputable source of information when it comes to all things nursing in general, but specifically I am a OB/GYN well baby nursery nurse. And I still do work in the hospital, PRN, and I am a nurse educator, like I said. So I have nursing students that I actually go to clinical with and actually do the didactic portion at some institutions. Didactic is the classroom component of your lectures. So that is me in a nutshell. So I think for those who are new to my channel, subscribing, that's what I'm pretty much about. This channel does also encompass other things that I'm into, such as makeup and fashion. I am plus size, so you will see some videos from time to time about plus size fashion and things that I'm into, try-on hauls and such, makeup and empties and just different things I'm into. All right, with that being said, let's go ahead and jump right into what this video is about. As I have promised, I am going to talk about, I cannot do because I'm not in a classroom setting, but we're going to talk about the postpartum assessment, and we're going to use the acronym B.U.B.B.L.E. So it's B.U.B.B.L.E. H.E.R. B.U.B.B.L.E. And we're going to use that acronym because that is what I use with my students, with my nursing students, to help them focus on their postpartum assessment. That way they are all inclusive with that assessment, and they kind of know from head to toe a more linear fashion about how to go about that assessment. So that's what we're going to do, is the postpartum assessment, focused assessment using the B.U.B.B.L.E acronym. And I'm going to go through each of those letters and tell you exactly what I'm assessing for when I am doing my assessment on my patient, or what I'm teaching my students anyway. So again, I am a registered nurse. I am a postpartum nurse. This is my specialty. I know exactly what I'm talking about. Some of you if you are already a nurse, you may have learned this acronym differently. B.U.B.B.L.E is what I've heard before, but B.U.B.B.L.E is what I currently use with my nursing students to give them a whole perspective of how to care for their postpartum patient. So with that being said, let's go ahead and jump right in. The first B in B.U.B.B.L.E is for breast, B-R-E-A-S-T, breast. Okay, so with the breast assessment, what we want to know is if the breast tissue is soft, filling, or firm, or engorged. And I'm going to explain to you what each of those are. So soft, filling, firm, or engorged. The best way for me to actually assess breast tissue is if you think about when you listen to your heart and lung sounds on your patient, where do your hands naturally fall? They fall on the breast tissue. So your heart is over here on the left side for most people. I had somebody tell me the heart was on the right side. Okay, that's rare. But anyway, for most people, it's on the left side. So when you place your stethoscope, the diaphragm stethoscope, on your patient's chest, your hand naturally falls on her breast tissue. At that point right there, you can kind of feel, without actually feeling, what her breast tissue feels like. So is it soft? Is her breast tissue soft? Is it feeling like the milk is beginning to come in? Is it full, like they're large, or is it engorged where you can see those blue veins coming through and things like that? You will know if you've never seen engorgement before, you will know it when you see it. So that's something you know, if you've never seen it before, you can either go look it up, but you will know it when you see engorged breast. So that's the first part that I do with my assessment. And of course, you're going to do both sides. So when you listen to heart sounds over here, lung sounds over here, you're listening to lung sounds over here. So my left, my right. So on my left side, I'm listening to heart sounds and lung sounds, and I can also feel breast tissue. Same thing is true on the right side. I'm only listening to lung sounds, obviously, and I can also feel breast tissue. Again, my hand naturally falls on your breast tissue when you strategically hold your diaphragm of your stethoscope in the appropriate locations for heart and lung sounds. That's where they naturally fall. All right, the next is the U. U stands for uterus. So when we are doing the uterus, we are wanting to know specifically where the patient's fundus is, the top of the uterus, where her fundus lies, comparatively to her umbilicus. So I don't have a mannequin here, so what I'm going to have to do is use me as an example. I am not going to pull my shirt up or anything like that. However, as a frame of reference, I will tell you where my belly button is and kind of what we're feeling for. So this is going to be best illustrated actually on a mannequin. I do not have one in my home, but if I ever get a chance to redo this at a facility, I definitely will do so that you can see what I'm talking about. So when it comes specifically, let me stand up to, hold on. All right, so I'm not gonna be fully in frame, and that's okay. So you're not gonna see my face, so much of it anyway. But I want us to focus on this part right here. As a reference, my belly button is right here in the middle. All this right here is my side. When it comes to the uterus itself, we have to keep in mind, we wanna know where the fundus is. Now, if you've been pregnant before, all of this will house the uterus in terms of after you have a baby. All of this will be uterus because guess what? Most moms get to about 40 weeks gestation or around there, 35, 36, 37, 41, something like that. So all this will be uterus. What we want to know is where the fundus is. Fundus means top. We want to know where the top of that uterus is in relation to the umbilicus right here. My umbilicus anyway, right here. I always tell people to support your patient on her mons area, which is the pubic area down here. Let me see if I can adjust for you. So the mons area is down here. Now you don't know what the mons area is. That is the area in which usually the pubic hair is. If she's not shaved, it's down here. You're going to support her here. If you do not support her here, you can inadvertently, when you're trying to find that fundus, you can inadvertently push her uterus right on out. And that is something that we don't want to do. So we're going to support her on her mons with one hand. I usually say your non-dominant hand, whichever hand you choose. You're going to use your fingers, your fingertips, and we're going to start up here. I like to start up here because of the fact that I know there should not be a fundus up here or uterus all the way up here underneath the breast. Some nurses you will see will start right at the belly button and say, oh, that's where it's at, right here at the belly button. Problem with that is it could actually be above the belly button and you've still missed it. So I always tell my students to start up here where we know there is no uterus or should not be any uterus. Most women have that line called the linea nigra, which is a dark line that runs down usually the midline of the abdomen. And no matter what race you are, ethnicity you are, most women still have that line. It can be faint, but it's still called the linea nigra no matter what ethnicity you are or race you are. So I tell students to use their fingertips only, support down here, start right here underneath the breast, near the xiphoid process, and simply go right down the middle, pushing in until they find the top of that fundus. And they will notice a ridge or something more firm, typically more firm around the umbilicus or below or even above. It just depends on where they are in relation to their recovery period. So again, just a recap, support on the mons, use your other hand. This is a glove, for me personally, this is a gloved procedure because I am not touching anybody unless I have gloves on, especially the closer I get to the vaginal area. That's just me. You do what you want. But I do have gloves on when I'm doing this because my hand is on their mons area, okay? Keep that in mind. Everything down here is considered to be dirty. So I, again, support here, use my other hand, work my way down using my fingertips only. Your fingertips have those nerve endings in it that you can better assess and feel. And whenever you find the top of her fundus, you will mark that in terms of where is it in relation to the umbilicus. So let's pretend I found my fundus, which my fundus should be down here in my pelvis. Why? Because I'm not pregnant. Hadn't had a baby in 7 years. So my uterus is down here. Your uterus is about the size of a fist, and it sits down here, okay? If you're not pregnant. Now, so mine is truly down here. But for dramatization, let's just say mine is at the umbilicus. So I would say my fundus is firm. And how do I know it's firm? Because I'm massaging it, I'm rubbing it, and I can feel that it's getting hard underneath my my fingertips. Now, again, this is for dramatization only. I'm not pregnant. My fundus is really not here, but I'm just trying to tell you exactly how we would go about doing it. So my fundus is considered to be firm at the umbilicus, and that's kind of how we document that. Fundus firm at U, which stands for umbilicus. Now, let's say, for instance, you can't see, but let's say this is my belly button here. Let's say the top of the fundus is here, where this finger is right here. That would be considered to be one below the umbilicus. Let's say the top of my fundus is here. This will be 2 finger breaths below the umbilicus. Let's say it's down here. The top of my fundus is right here. That will be considered 1, 2, 3 finger breaths below the umbilicus. On the flip side of that, let's say I find my fundus, which is the top of my uterus, right here. That's considered 1 finger breath above, 1 finger breath above the umbilicus. Let's say I find it here, right here. That's 2 finger breaths above the umbilicus, and so forth. So your uterus or fundus could be really at any point down the middle. So we talked about fundal placement and fundal height. I'm talking about now some situations in which it may not be considered midline. You want it midline typically, in the middle, where that linea nigra line is. But there's some times in which it may not be considered in the middle. And times like that include when her bladder is full. So we always want to assess and ask our patients, when's the last time you went to the bathroom? And based off of that, she can tell us when she went to the bathroom last. If she said that she went to the bathroom 8 hours ago, well, her bladder could be full, pushing her uterus up and over, because the bladder sits beneath the uterus. So in terms of an A&P, bladder's down here. Excuse me. Uterus is up here. The bladder can push the uterus up and over to the left or right, causing it to be deviated. When we do have those situations, we can have increased bleeding. Keep in mind, if the uterus cannot contract, and it can't contract if the bladder is full, her bleeding will increase. So in a nutshell, that is about the uterus, or the fundus, is which we're trying to find. We want to know, is it firm, which is what we're trying to assess for? Or if it's not firm, is it firm with massage? Meaning when I rub that fundus, it gets firmer with massage. Or is it just considered boggy, in which it's very just hard to detect? You really can't find. Boggy is bad. Boggy, bad. Remember that boggy is always bad. You never document boggy and don't document an intervention. The same way as if you wouldn't document code blue and then didn't do anything about it. If somebody is not breathing, you had to call, do a code blue. That means, excuse me. That means you had to do CPR. You had to do an intervention. Boggy is bad. It means we need an intervention. Vigorous fundal massage. Anyway, so B, breast. U, uterus, where we're trying to find the fundus. We're trying to find it in relation to the umbilicus. We're going to provide support. We're going to do use our fingertips, work our way down. Also, the position of your bed is very important for this step. So she needs to be at a roughly, not necessarily flat, but no more than like a 30-degree angle when you are doing her fundal assessment. So meaning her bed has to be either flat or roughly about a 30-degree angle to do her fundal assessment. If she's sitting up at a 90-degree angle, guess what her uterus is doing? It's sitting up at a 90-degree angle, so you will not get an accurate assessment. You need her to be laying relatively flat. Now, we do have patients who, if they're 400 pounds, them being flat like this is probably not an option because they can't breathe. So therefore, you want to make sure that, you know, she has to be at a somewhat elevation so that she can breathe. It defeats the purpose if she's not breathing. And but otherwise, they do need to be relatively flat. So that's the positioning has to be relatively flat, not at a 90-degree angle, which means if they're sitting up in a chair at bedside, you cannot get an accurate assessment doing that. I always have my patients get back in the bed so I can lay them down either flat or relatively flat to do their assessment. Let's go on to the next B. So we talked about breast, we talked about uterus. The next B, or the next two B's, is bowel and bladder. Bladder, bowel, however you want to go, what order you want to go in, it doesn't make a difference. They're both B and B. We'll start with bladder for the sake of this video. Bladder, you basically want them to have an empty bladder when you're doing their assessment. You want to know when's the last time they went to go pee. You want to know how difficult is it for them to go pee. You want to know, do they have any burning when they have to go pee. Now, when you have a fresh C-section or cesarean section patient, keep in mind she will probably have a catheter for the first 12 plus hours. So therefore, when it comes to her emptying her bladder, you automatically know what her urine looks like. You understand the characteristics of it, or not understand, you can see the characteristics of it. You're able to document whether it is clear, yellow, amber, concentrated, is it bloody, blood tinged, whatever you want to call it. You'll be able to document that. Does it have sediment in it, blood in it? You'll be able to document that accordingly. Same thing if they're voiding into one of those hats or whatever we call them, a hat you put in the toilet. So be mindful of that, and that is basically what we want to know. When's the last time you went to the bathroom? We want to make sure if she's a fresh delivery, she just delivered, say, within the past couple of hours, that she can void. Every hospital has their own policies about when to start catheters and things like that. Just know that you need to follow your hospital's protocol. Ours is about 6 hours that we give them to go pee. If they are unable to void within 2 hours post-delivery, we will in and out cath them and then give them an additional 6 hours to go pee. If they cannot pee within that next 6 hours, depending on the physician, we either in and out cath again and give them an additional 6 hours, or we just place a Foley until the next day when the doctor comes and says, okay, remove the Foley. So it just depends on the hospital policy and what goes on with that. So be mindful of that. The next B is, we're going to say it's going to be bowel. So how long do you all think it takes for somebody to go poop after having a baby? So the one thing that I say, the two populations of patients that are preoccupied with pooping are your geriatrics. They're always preoccupied with going to go poop. And your OB patients are always preoccupied with going to go poop. So how long do you all think does it take for them to go poop after having a baby? It just depends on the patient, obviously. What I tell my students is this. Their textbooks will tell them, oh, everybody goes to poop within this many days. Actually, you wouldn't know when everybody goes poops unless you go give them like a laxative or a suppository or something to make them go poop. Otherwise, everybody has their own bowel patterns. So if you are someone who, or if your patient is someone who is a vegan, or they just have a plant-based diet, they will go to the bathroom sooner and more often than someone who has a more processed food diet. So I just give my patients about a week. At our facility, you do not have to poop to go home. At our facility, you do not have to poop to go home. You have to pass gas, but you do not have to poop to go home. So I just tell my patients that they need to eat very good food. They need to eat, you know, roughage, fresh fruits, vegetables, drink plenty of water, juices that they may like. I wouldn't really recommend them eating spicy foods. Sometimes spicy food helps you go to the bathroom. I don't recommend spicy food, especially if they're breastfeeding, because that can upset baby's stomach. But be mindful that, you know, things that help them go, I'm going to encourage them to take those medications, not medications, but like foods and things like that, that helps them go. We do give our patients stool softeners to help in that situation, not to make them go, but to make it easier for them to go when it's time. Keep in mind what a stool softener does. It allows the body to reabsorb water so you don't get rid of it. Therefore, it makes the stool soft. As a result of that, for some patients, when it continues to reabsorb water, it makes the stool so soft that they have diarrhea. Once they have diarrhea, it is time to stop the stool softeners, just so you know. At least we hold our stool softeners if the patient has diarrhea. So be mindful of that. But for the most part, we're going to give them stool softeners 2 to 3 times a day per order. And we're going to encourage them to do the things that I just said in terms of, for one, movement to help with peristalsis. So get up, move, be active, and then do the things, the diet modifications that we just talked about. All right, so now we've talked about the breasts. We've talked about the uterus and how to find the fundus, the top of the uterus. We've talked about bladder. We talked about bowel. So B.U.B.B.L. is the lochia. Lochia is what the blood is called that comes out after you have a baby. We call it lochia. It's very reminiscent of menstrual blood. However, the reasons as to why you have a menses compared to why you have lochia are 2 different reasons, but the mechanisms are the same. So when I say that, I'm saying that with lochia, it is, you bleed, in case you didn't know, you are bleeding because you had placental detachment. So once the baby came out, the baby's lifeline, which is the placenta, had to detach from the uterine wall. When they detached from the uterine wall, then that's what causes the bleeding. It's like having a scar. So basically, if I was to cut my arm right here, I'm going to bleed, okay? And then once that scab heals or scab covers it, I will stop bleeding. Same thing in that area. A scab will, basically a scab or something will form, okay? A scar will be there. That's why we have scar tissue when we have C-sections and we go in there and see there's plenty of scar tissue because they've had babies before. It's because that's where the placenta detached previously. So with that being said, that's why we bleed. And C-sections bleed the same. Why? Because they still have placental detachment. It is not because the baby came through the vaginal canal as to why you bleed. It's because of the fact that that placenta detachment in both situations is why we bleed when we bleed after having a baby. So there's 3 kinds of lochia. There is Lochia rubra, which is what you see in the hospital, their patients in the hospital. It's usually that bright red to dark red. There's some clots, no clots, that kind of bleeding. It's pretty heavy at the beginning. On the first day or 2, it's very heavy, and then it kind of tapers. It should mimic your period in terms of how the flow is, except for it's going to be heavier. You just had a baby. We expect our patients to lose roughly between 500 to 1,000 mLs of blood after delivery. So 500 typically for a vaginal delivery, right at 1,000 or so less for a C-section. That's our estimated blood loss that we project them to have before we think they're gonna hemorrhage or things like that. So we expect that. So we want to make sure we watch how much the patient is bleeding. When I'm doing my fundal massage, I'm pulling down my patient's panties and I'm looking at that pad to see how much blood is on that pad. That is imperative that you do that, because if you do not look at that patient's pad, you cannot truly assess how their bleeding has been. And when I look at that pad, the first thing I say is, how long has this pad been on? And if they tell me it's been on for 30 minutes, but the pad is completely full from tip to tip, that's not good. That means we may be hemorrhaging. If they've had that pad on for 4 hours and it's halfway full, then I may not be as concerned about that. That may be considered small lochia. I will come back and do a video just with pads with blood on them, not real blood, synthetic blood, to show you what I mean by small, moderate, saturated, and things like that. I should have did it for this video, but I didn't think about it, and I'm at home, so I don't have those kind of supplies, and I don't have synthetic blood here at home. I have that at my job at the school, so I will probably get some pads and make some and bring them to you to show a video on what lochia looks like. But anyway, after Lochia rubra, which is what you see in the hospital, there's Lochia serosa. And serosa is more of that pinky red bleeding that you have. Think about your menstrual period, ladies, if you are, how you go through that menstrual cycle. So at the beginning of your period, you have that usually brightest, reddest blood. It's usually more heavier. And then probably a few days into it, you'll go to more of a pinkish kind of color, when you wipe it's just more of a pinky color. And then towards the end of that cycle, it will be more of a white, what we call alba color. It does the exact same thing with the pregnancy, except the reasons are different, like I said, and it takes longer. Women bleed for about up to 4 to 6 weeks postpartum, and after that they will usually stop, And if they're breastfeeding, it may have a component whether they start the period right back or not. But for the most part, women start back their periods within 2 months after delivery, depending on the woman and depending on if she's breastfeeding or not. There's women who breastfeed and their periods still start back like clockwork. And there's women who breastfeed and their periods don't start back for the entire time that they're breastfeeding. So it just depends on the woman and her body and what her body does. Everything when it comes to OB or just nursing in general is not black and white. It's very much gray. So you take what your textbooks say to you and then, you know, apply it to your patient. Don't apply the textbook. You take the patient and apply it, you take the patient and apply it to the scenario, not the textbook, and apply it to the patient, meaning that every patient has to be like the textbook says, because that's not how women are made, okay? Or anybody's made, really. So that's the B.U.B.B.L. E is the episiotomy laceration. Now, the episiotomy laceration is just where we look at the perineal area. So keep in mind, you have to look down there. And you have the vaginal opening, you have the rectal opening. In between there is skin, okay? And in that area, that's where the episiotomy, which means the physician cut down to allow a larger opening for the baby's body and head and body to descend. Or a laceration where her body tore naturally along natural lines. And either way, you have to be stitched back up. So if they cut you, or you tore. So a cut is episiotomy. The doctor just took some scissors or whatever, just snipped that perineum right on down. Most women usually have an epidural or some kind of local or something when that happens. But if not, then it feels exactly how you think it would feel. And then, or lacerations when your body tears naturally as the baby is coming out. The body will, the perineum will tear. And again, like I said, they will stitch those up. I have personally had a 2nd degree laceration, so my body tore on its own, and it was considered to be a 2nd degree laceration. I really won't get into what the degrees are and all that. Just know when you have a 4th degree, it means you are from rooter to the tutor cut, usually. Like usually they cut you. Usually don't tear that way, they usually cut you. But a 4th degree usually is where they've cut the whole perineum to allow that baby to descend. And you better believe that's probably painful. I wouldn't know, I've only had a 2nd degree, and a 2nd degree is bad enough for me because it hurt. I did have an epidural, so I didn't feel it in terms of when it happened. When they stitched me up, I didn't feel it. However, once that epidural wore off, yeah, I felt it then. I felt it. So anyways, just know the E is episiotomy, L is laceration, even though that part of the E, laceration doesn't start with the E, but it's the same area. I just want to be able to differentiate between the episiotomy and laceration so you'll know which one is which. And then we're going to go to H. So we did bubble, breast, uterus, bowel, bladder, lochia, episiotomy, laceration. H, this is the H.E.R part, bubble, H.E.R. The H is Homan sign and hemorrhoids. So hemorrhoids is pretty simple. You put them in a left lateral Sims, or just basically lateral Sims position. It would be left, but just a lateral Sims position. You have them lift that one leg up slightly. You will have your gloved hands on. You slightly spread their butt cheek apart, and you're looking in the rectal area to see if they have any hemorrhoids. And if they do, all we do is document it, give them the appropriate topicals such as witch hazel, or just like Tux pads, or we give them like Preparation H or some type of hemorrhoid cream, hydrocortisone cream, to help shrink those hemorrhoids. We don't push them back up in there, so that's a no-no. Some places do sitz baths, some places do different things like that, that they do, have them sit on donuts that they have to help relieve that pressure from that area. But for the most part, that's all we do. We want to assess and see if you have any, see what they look like, how many you have, how large they are, and give you appropriate treatment for your hemorrhoids. So then the other H is Homan sign. So H stands for Homans and hemorrhoids. Now, our students are being taught that Homan sign is contraindicated, and they say it's contraindicated because you could actually, when you dorsiflex the foot, dislodge a blood clot from their calf. And if you dislodge it and it breaks off, it's going to travel. And if it travels, it's going to travel to the heart, lungs, brain, and basically, and/or brain, and you be dead. So therefore, it's contraindicated. However, at my facility, we still do the Homan sign on all our patients. I don't really like the rationale as to why we are now not supposed to be doing the Homan sign. Excuse me. And the reason why I don't like the rationale is because of the fact that if my patient has a blood clot in her leg and she's in the hospital and it gets dislodged in the hospital, she's in the best place that she could be. Because otherwise, guess what? When she goes home, she's going to be doing her own thing, walking around her own house. And then she's going to just be walking around and all of a sudden have shortness of breath, can't breathe, O2 sets drop, she's dead. So, and they probably can't get her to the hospital fast enough because they don't know what's going on, because all of a sudden she's short of breath and we don't have the proper equipment at her house. So for me, if my patient's at the hospital and I dorsiflex her foot and I say, okay, do you have any calf pain? And she says no, then that's a negative Homan sign. You do both legs like that. If she says yes, that means we have to further investigate. With that being said, when we further investigate, the Homan sign is not diagnostic, it is a screening tool. So do not think when you have a positive Homan sign, you have diagnosed her with DVT or deep vein thrombosis. That is not what has happened. What you have done is said that yes, we do have a positive Homan sign because we have pain in her calf. That's all you are saying when you do a Homan sign test or screening, shall I say. So when she does tell me yes, when the patient tells me yes, the next thing I do is then basically assess her calves. I want to assess for signs and symptoms of deep vein thrombosis or DVT. When I do that, I am feeling for a warmth in the back of her calf. I'm comparing the right to the left. I'm seeing if there's a warm streak. I'm seeing there's nodules back there. I'm just basically seeing if there's just general warmth, largeness of the calf compared to the other one, swelling, things like that. That will prompt me to then go call the physician and say, we do have a positive Homan sign, and she does show signs and symptoms of a DVT by this, and this. Then it's up to that doctor to say, okay, let's go ahead and get a Doppler or whatever they do at your facility to rule this out. And then push come to shove, if we do have a true blood clot or we're thinking we do have a blood clot, then we will start them on something like Lovenox or some type of blood thinner or whatever we need to do to help make sure that we don't have those type of issues. So that's what we do at our facility. Every facility is different. If you all are nurses and you have these issues, put below what you all do at your facility, but that's what we do at ours. But anyway, Homan sign, again, is not a diagnostic tool, it's a screening tool. So make sure you understand what the difference is between those two. All right, so next we're going to go to the E. The E is for emotions and energy, and I usually throw psychosocial in there. Again, psychosocial does not begin with an E, I know that. But psychosocial does have a lot to do with your emotions and your energy. I just throw it in there because it's all one big thing. So I ask my students, what do you think, or how do you think emotionally a patient would be? And I typically get the answer, they are going to be tired, which yes, they are. They'll be tired for the rest of their lives because they just had this baby. And I'm still tired from having my 21-year-old. So guess what? You'll be tired for the rest of your life. Not just tell the patient, you'll be tired for the rest of your life. Rest of whoever's life, because you'll be tired. That's just the nature of having babies. So tired, they're emotional, they're crying sometimes, they're happy sometimes. Sometimes we already have patients who have postpartum depression, so they are not postpartum depression. They already have depression, an underlying diagnosis of depression. So we basically, if they have already a history of depression, then we know to watch for depression. And for our patients, we do depression screenings on our patients anyway upon admission to postpartum. Every patient upon admission to postpartum gets a postpartum depression screening. A score of 10 or higher warrants us to further investigate, call the doctor, and have social worker, whoever comes see them, whatever we got to do. Depends on the situation though, but that's what we do. So we have people, I want to tell you about the people we have demographically, and I've had other videos regarding this. Everybody who has a baby is not happy about it, okay? So don't think that OB is just this happy floor. We have people on drugs, like I've said before. I live in Tennessee. We are the third, what are we, the third in the world, not in the world, but in the U.S. for opioid crisis and addiction. So if we're number 3, that means we have a lot of people here in Tennessee who use and abuse drugs and, you know, things like that. So again, that goes with the psychosocial dynamics. We have people who, if they're positive for drugs, guess what? I have to call DCS on them, open a case. I have to call case management on them, open a case. Babies can be taken away from stuff like, for reasons like that. So we have to be mindful of those things when it comes to psychosocial. I live in the South, so the South is comparatively poorer compared to other areas or regions of the United States. Also, we have more health disparities than other regions of the United States. So therefore, we have people who are hypertensive and homeless. And psychosocial basically means, well, let's take away the disease processes because we have sick people here. Let's talk about the actual socioeconomic status or psychosocial aspect. If you're a single parent, if you are a 13-year-old having a baby, if you're a 40-year-old having a baby but you single and the daddy done left you, what do you think psychosocial your life is going to be like? And then add a baby to it. Think about if you've had 5 or 6 or 10 kids. You know, we've had people who come in having their 10th, 11th child. Do you think that's easy? That's a rhetorical question. The answer is no. It is not easy, okay? I have 4. I have 4 children and it's not easy. So you have to feed all these kids and you have to clothe all these kids and you have to house all these kids and they have to have transportation to get to the doctor's office and you have to make sure they get their shots if that's something you're into. You have to make sure that they're well groomed and fed, and it's expensive. So we have all that going on. So we have psychosocial. We think about those types of things. So we think about depression, psychosocial. We think about do you have roaches at your house? Do you have, running water at your house? We don't have people who always have those types of things. So we have to make sure that we are an advocate for our patients so that we send them home in this best environment that we can send them home in. We've had situations where our patients will come and they will have used an old car seat. So maybe someone had gave them a car seat or something like that, and they housed the car seat, let's just say, in their garage. And if you know anything about car seats, especially in garages, spiders and bugs like to be in dark, warm places. And we've had situations where they will bring this old car seat to the hospital, and all of a sudden we've had where spider eggs have hatched. No pun intended, but they hatched in the OB ward. They knew where to have their babies at. So we have now baby spiders running around all over the room where we've had to quarantine the room off and get everybody out and throw the car seat away. It's like, you can't take the baby home in this car seat. So everybody doesn't come prepared to have a baby is what I'm trying to say. Everybody does not come prepared, with their car seat in hand, and that's just not the reality of how nursing works. So, or how OB works, or how our patient population is. It's not what you think it is. So we have to deal with the psychosocial dynamics of that. We have same-sex couples, okay? So we have same-sex couples, whether it be 2 women or 2 men. We have surrogates. We have adoption situations. We have the stories I just told you, poor. We have indigent, people who don't even speak the language, no insurance. We have drug people. We have everything. The people who have they're sick, meaning that we have either mental health issues or we have a lot of mental health. I had a patient who was psychotic about a month ago. She had schizophrenia and she was psychotic, and we had to call the state, had to take the baby. It was just a bad situation. So that's an example. Like, I had my first psychotic patient about a month ago who when I tell you, she said the baby looked like the devil. The baby was the devil. We had to have a sitter for her. The baby could not be left in the room alone with her. And that's just kind of how it was. So, I had to learn how to handle that situation because I've never had truly a psychotic patient who is actively psychotic, actively seeing the devil. She could see horns coming out my head. I would ask her, what are you seeing? What are you hearing? Type of thing. And she would just sit there and just stare at me like she's looking through me type of thing. That was scary. That was very, very scary. So even for me, for safety reasons, I'm like, what do I remember from mental health when I was in my mental health rotation in school? I always remember, keep my back towards the door. I need to be able to get out. I need to get out if I need to. I left my patient's door open. I just pulled her curtain. We had her closest to the nursing station. So we had to take provisions for her. That's the psychosocial that I'm talking about. So the H was the Homans and hemorrhoids. The E was the emotions, energy, psychosocial, and the R. Last but not least, the R is Rhogam and rubella. If you know anything about blood typing and things like that, and antibodies and Rh factor, just know the most simplest way for me to explain it is this. You need to read your textbook if you want to know the details of how this works. But if if her blood type is A, B, AB, or O negative, then we are going to test and see what baby's blood type is. If baby's blood type is any of those things positive, so A, B, AB, or O positive, mom's getting Rhogam before discharge, within 72 hours of delivery, period. She also would have gotten her first dose of Rhogam about 28 weeks gestation if she was doing her prenatal care as she should have been. She's going to get her first dose at 28 weeks no matter what, and her second dose will be based upon the lab results for baby's blood type. So again, if she is A, B, AB, O negative, and baby is A, B, AB, O positive, mom is getting Rhogam within 72 hours of delivery. If mom is any of those things positive, A, B, AB, O positive, nothing happens to baby. Basically, the reason why we're giving the Rhogam is because of the fact that mom has produced antibodies that could potentially reject the next baby. Not this one, the next, because this baby's already out. So the next baby, her body could reject. So think about this. Anything that is foreign to our bodies, we will reject. We get rid of it. So same thing true with the baby. So we want to make sure we protect the next baby. So that's the reason why she gets the Rhogam injection. Rubella, as you know, is part of the MMR series, measles, mumps, rubella series. And so therefore, if she's getting the MMR, or if she is rubella non-immune or equivocal, that means she's a candidate to get the MMR vaccine. We don't give it without consent. Equivocal basically means that when they did the titer results revealed that it didn't know one way or the other whether you were positive or negative or immune or non-immune. For the sake of immunity, you're considered to be non-immune. So you're non-immune or equivocal, meaning that you're either way. They don't really know. The test can really differentiate. You're considered to be non-immune for the sake of whether you get the vaccine or not. And again, you have to consent to it. It is a live virus. We tell them upon when they get this that it's a live virus and that you do not need to get pregnant in the next few months, I think 90 days. And if they still consent to it, they sign consent and we give them that vaccine upon discharge. So in a nutshell, that is our B.U.B.B.L.E assessment. That is the focused assessment for postpartum. You are still doing your lung sounds, heart sounds, bowel sounds, pulses. You're still doing, people still do the Perla. I don't, but we still do, some of you still do the Perla. We don't do, our floor, we don't do the strengths and grips and all that, but if it's something you're required to do on your floor, continue to do so. But all your pulses, all those things that you normally would do, you're still going to do those things. Skin turgor, when you're checking for dry skin, falls assessment, Braden skin assessment, you're just going to do all those things. The only thing that I am talking about right now is your focused postpartum assessment. So postpartum wise, that's what I do from head to toe, but I still do my heart sounds, lung sounds, bowel sounds. I usually do all my listening first. And then after that, I go into the actual assessment itself. So hopefully this has been helpful for you. I've left out a few things. I will come back and probably do a video on those pads that I told you about, the Lochia, so you can see what I mean by small, moderate, and heavy saturated Lochia. I also will probably do a video, do this again if I can in the lab when I get to when I go to the school that I teach at. I will possibly see if somebody can record me, or I can just record myself somehow with a tripod doing the B.U.B.B.L.E on the mannequin so you can actually see it. But if nothing else, you hopefully be able to take notes and be able to listen to what I was saying and just kind of, you know, go systematically down. I always tell my patients that if we don't do anything else, our focus is from the breast to the vaginal area. If nothing else, if I don't do anything else, I have to do that. Now, mind you, if I come in and talk to you and you're telling me you seem like you're breathing okay, then I know you're alive, obviously. But obviously still have to do vital signs and ask about our pain, which is our 5th vital sign. So anyway, hopefully this has been helpful. If you have any other videos you want me to do, please leave those comments below, or you can DM me, inbox me. If you look at the YouTube banner, you will see 2 icons for IG. One of them is basically my nursing counterpart, if you will, to this channel. So it's Melanin RN. It is the Nurse Lounge over there as well. Melanin RN _ MPN. So MELANIN RN _ MPN is what it is. If you cannot go to those banners up there and find it. The other one is my plus size journey. I am a plus size woman and I love fashion, makeup, and things like that. And I really want to empower women who are plus size, such as myself. that you are equally as beautiful. So that's what that page is if you want to follow that one as well. But until the next time, you all take care. Bye-bye.